Hello, welcome everybody. Arthur Sinodinos here in a rather snowbound Washington, but what a wonderful webinar we've got for you this afternoon with some really special people on a panel on a subject that I'm very keen on. It's the G'day US Australia dialogue on medical innovation in response to COVID-19. Again, a way of bringing together some great minds to talk about how medical innovation has responded to COVID-19 and what that says about the US and Australia, about our capacities to innovate together and what that means for the future, not just in the context of COVID-19, but going on. I want to take the opportunity to thank my good friend John Berry and the AAA for their role in G'day USA. Every year we have events in person. This year, there are events like this, but we're looking forward to getting back together with everybody. We've got a great panel today, and I want to begin by acknowledging Kathy Foley, who's just been announced as our Chief Scientist. Thank you, Kathy, for taking on the job of moderator and keeping these great minds under control. We've got the Honourable Kathleen Sibelius, the former US Secretary of Health and Human Services. Thank you, Kathleen, for making yourself available for this. We've got Professor Rayna McIntyre, who's become a bit of a media hit during this period. Rayna heads the biosecurity program at the Kirby Institute at the University of New South Wales, and she's been giving great commentary and advice right throughout this period. Thank you, Rayna, for joining us. And two great innovators, Paul Pirro, the CEO of CSL, which began life as the Commonwealth Serum Laboratories, and look where it's ended up. What a fantastic success story. And Mick Farrel, CEO of ResMed, again, another fantastic success story, both indicators of how medical innovation can lead to great job and industry outcomes. You can have great innovation, you can have great ideas, but the capacity of CSL and ResMed and role models like them to translate those ideas into life-saving products is not only a great public service, but it's a fantastic indication of what innovation can do in a commercial sense. So thanks, Paul and Mick, for your time. Fantastic to have you here. I'm a big believer, and I'm biased, of course, but I've had some experience of this. I'm a great believer in Australian medical research and innovation. I think we have a lot of the resources which help us to punch above our weight internationally in that sector. And so I'm always a believer in how do we get more resources into the sector to promote the innovation and promote the commercialization. It's the commercialization bit which we still have, I think, a challenge with in Australia. That's why role models like CSL and ResMed are so important. But today is a day to reflect on how that innovation has been brought to bear on a problem that we didn't think was going to happen, or at least most people didn't think was going to happen. A once in a century event, which has fundamentally changed the lives of many people. So today is an opportunity to reflect on the various aspects of that. I'm interested in what Kathleen will have to say about responses here in the US, and also about how a big country like the US and a country like Australia can cooperate together in terms of public policy outcomes. And I'm interested in what Rayna's got to say with her Australian perspective on how we can do more to promote ourselves as a source of innovation and in global responses to COVID-19. And to Paul and Mick, again, just to hear the stories of how you have responded in these circumstances and what that means for other companies when they're thinking about how they respond to challenging circumstances. It was mentioned to me earlier that the New South Wales government has kindly agreed to a breakout session after this. John Berry will give you more details of that. All that remains for me to do is to cross over to Kathy Foley, our Chief Scientist. Again, congratulations on the job. You're a great role model to young boys and girls thinking about what the future holds in the whole STEM space. So over to you, Kathy.
Thanks, Ambassador, and it's really a great honour to be here today. This is my first international interaction in my role as of Australia's Chief Scientist. And the thing that's really great is that my connections with the USA over many years have been deep and strong and enduring. And so this is a really wonderful chance for me to build on that as I take on my new role. So today we've got this great team together, and I have the great honor of moderating and introducing everyone. So let's get this going. And our first speaker today is Professor Rayna McIntyre, and she's the NH and MRC Principal Research Fellow and Professor of Global Biosecurity, as well as heading the Biosecurity Program at the Kirby Institute at the University of New South Wales. Her research is underpinned by her clinical training, vaccine program experience, and extensive field outbreak investigation experience. And she has a 28-year track record in pandemics, epidemic infections, serious emerging infections, vaccines, and control of respiratory viruses. Is best known for her research in the detailed understanding of the transmission dynamics and prevention of infectious diseases, particularly respiratory pathogens such as influenza and tuberculosis. And she has led the largest body of research internationally on face masks, respirators in healthcare workers, and her research has been influential in forming guidelines for health workers on PPE. We're fortunate to have Professor Rayna McIntyre to join us today and give us her perspective. So over to you, Rayna.
Thank you, Dr. Foley. And hopefully you can see my screen. Ambassador, Honourable Secretary Sibelius, distinguished speakers, and Dr. Foley. I'm going to talk a bit about a different kind of innovation to get you thinking about the possibilities. We've been involved at UNSW in something called the PLUS Alliance, which is an alliance with Arizona State University, where I'm an adjunct professor, and King's College London. And we've created together very innovative teaching programs online. And we ran a pandemic exercise as COVID was beginning, unknown to the world, in Washington, DC in December 2019, where we anticipated many of the issues, not all, but many of the issues that might arise during a serious pandemic. And this was done with Indo-Pacific Command in Honolulu as well. And they started engaging with us in 2018 when we first did a pandemic exercise in Australia. And I got invited to be on Team USA in a Bangladesh-US joint military subject matter expert event in Bangladesh, which was where we ran our pandemic simulation there. And then we also did it at Pearl Harbor for the people at Indo-PACOM, which is a pandemic exercise. Innovation, I think you'll hear from the other speakers about biomedical innovation. Just to mention that at the Kirby Institute, we do have a SARS-CoV-2 lab, and Associate Professor Stuart Turville, who heads that up, is working with CSL and has developed some novel methods to do mass serology screening, as well as, of course, the other important thing that Australia has done very well is gene sequencing. We know that that has been lagging a bit in the US, and without the gene sequencing, it's hard to tell how widespread these variants of concern are. So I want to talk a bit about genesis of epidemics. So generally we invest in at the very pointy end of things. So when an epidemic is really, established, we start developing drugs and vaccines and maybe diagnostics. A lot of hospital clinicians think that detecting epidemics through syndromic surveillance in emergency departments is the cutting edge, but it's really not. By the time you start noticing something's going on in the hospital, it's usually quite late. And by the time the notifications start arriving on the desk at the health department, it's also very late. What if we had detected the COVID pandemic before it had spread outside of China, when it was just a few cases or a handful of cases? It could have been stopped. The whole pandemic could have been prevented by simply isolating cases and tracking the contacts and quarantining them. That would have prevented it spreading. So I'm going to talk about this very early stage of the genesis of epidemics and the innovation that is possible there, mainly because we have vast amounts of uncurated open source data. People talk about what's happening in communities. News agencies report on strange outbreaks long before any health departments know about it. And in fact, since 9/11, law enforcement has been very good at using this open source data to look at signals for planned terrorism attacks. But in public health, we're extremely old-fashioned in Western countries, particularly. Some Asian countries do use this kind of technology. But in Western countries, we've been slow to adopt this. And it's not a privacy issue because we're not talking about breaching anybody's privacy. This is accessible open source data. So we've developed over the last 5 years, through a lot of blood, sweat and tears and not much funding, we've developed an open source epidemic observatory called Epiwatch, where we use machine learning and artificial intelligence to actually fine tune those epidemic signals and throw out the garbage and try to get it as precise as possible. And we've also really worked on developing regional languages, which is of interest to the US. You know, Asia and Pacific is a region of interest to the US as well. So we've developed search capability in Malay, Indonesian, Hindi, Chinese, and other regional languages. And when we look back retrospectively, we were actually able to get a signal that there was a strange pneumonia of concern in Hubei province in China in mid-November. So remember that WHO only knew about it at the end of December. We've also been working with Data 61 at CSIRO using Twitter to look at what people are talking about. And we've published some of that research, including being able to identify the signal for thunderstorm asthma in 2016, where 8,000 people went to hospital on one night and several people died from some severe exposure through the air that night through a storm. And we were able to pick up a signal 9 hours before any health authorities knew there was anything going on. Similarly, for the Ebola epidemic in 2014, we picked up a signal for that epidemic 3 months before WHO knew there was anything happening. And that's in West Africa, where use of smartphones is not that high. So even in that kind of context, we were able to pick up that signal. And just to finish off, to say that this announcement came out from the White House that the US is forming a national center for epidemic forecasting and outbreak analytics, which is a great step in the right direction. Because if we can pick up these epidemics before they spread, we can prevent pandemics. So thank you.
Thanks so much, Rayna. And the idea of using social media as a crystal ball to allow us to have preparedness and early indications is very exciting indeed. So thanks for that. Now it's a huge honor for me to introduce the Honorable Kathleen Sibelius, who's a former Secretary of the US Health and Human Services and former Governor of Kansas. Kathleen Sibelius is one of America's foremost experts in national and global health issues and human services and executive leadership. Kathleen served as President Barack Obama's cabinet 21st Secretary of the Department of Health and Human Services, where she worked to pass and implement the Affordable Care Act. She's also been serving in the past as the governor of Kansas from 2003 to 2009, and was identified by Time magazine as one of America's top 5 governors at that time. She's had many honors and also many roles, but I think we probably prefer to hear from her because she is such an amazing person. So it is a great honor to invite the Honorable Kathleen Sibelius to give us her perspectives here. So over to you, Kathleen.
Well, thank you so much, Dr. Foley. And it's really a great honor to be with all of you, this esteemed group of government leaders and scientists, CEOs, healthcare professionals, researchers. And I should start by telling you, Dr. Foley, you now have a counterpart in the United States. There is once again a chief science officer. So you and Anthony Fauci can be best buddies, going forward.
I look forward to that. Thank you.
It's been coming for a while. I'm really kind of humbled to be with you all today, because as we try to unpack a little bit of lessons learned or lessons in learning with COVID-19, I think Australia represents the best case scenario and the United States represents the worst case scenario. So we could be taught in a public health course 25 years from now as the way to do things and the way absolutely not to do things. And I think that's important to take a look at. I don't think there's any question that the Australian government early, clear, national plan of how to tackle this emerging pandemic has been extraordinarily successful. And I was struck, I read some of the December McKinsey report on the focus that Australia has had. And I think the three things they talk about are building trust, using data, and collaborating well. And I would say that we, again, in the US are kind of an example of those three things going very much awry. And what happens when you have political leaders contradict scientific leaders and try to manipulate data in a way that is more favorable. I do think the good news is that we have a new administration in Washington who once again will lead with science and scientists. And that gives us a great opportunity to turn a corner. We have a lot of work to do here in the US, and we are still reeling from the worst case scenario in terms of, I think we now crossed 425,000 deaths, more than lost in all of World War II. We have hospitals throughout this country still filled to capacity. We are beginning to stumble into vaccine rollout, which hopefully will be renationalized soon as the Biden team can get their handle around what has been a very, very decentralized and confusing early days. What went well in the US, I think, is the effort, the so-called Operation Warp Speed. I'm not really fond of the name, but I'm fond of the results, which was a pretty inspired collaboration of the best of scientific minds globally, along with the might and muscle of the United States government, putting both money behind a number of bets on vaccine development, but also clearing the way through what could have been serious regulatory barriers and an effort to really move this forward as rapidly as possible. And the result of that has been very encouraging, with some very successful vaccines already authorized and more in the pipeline that look like they're going to be authorized. But that is the single component where really, I think, the kind of effort that, again, Australia, I think, has done well from the beginning, which is the public government, the national government, having a plan, having a communication strategy, leading with science and data, muscling their unique logistical capability, distribution capability, buying chain, and collaborating with our world partners would have been highly successful in other areas. We're going to spend some time in the US kind of coming back into the world scene. So we are rejoining the efforts at the World Health Organization. We will put government money finally into Novax and make sure that CEPI efforts are funded. What we know is that this virus will not be crushed until it is really crushed globally, and that will require the United States to very much rejoin the world community. The good news for a topic like today is that means there will be a lot of interest and eagerness to, again, collaborate, perhaps in ways that we hadn't been so good at before, to reach broadly across the global spectrum and recognize that we have a lot to learn. The kinds of things that Dr. McIntyre just talked about. There is a global health security agenda that was launched in 2014, which now includes 100 countries, including Australia. It was launched in the US in the midst of a big snowstorm, but people were so eager to be a part of it that they ended up walking to the department and signing up. But it's an effort that really trains epidemiologists in various regions in the globe and then is able to deploy them nimbly and rapidly using field research and really being on the ground. It was one of the success stories in some of the Ebola cases to be able to deploy a group of trained individuals. And I think that effort, like most of our global efforts, were ground to a halt in the last 4 years, but again, will be revitalized. So this is a great time to talk about the future and talk about collaboration and cooperation. And certainly, I think you will find a United States eager to learn the lessons on public health that you can teach our country, the kind of contact tracing and wastewater studies that were done successfully in Australia weren't even attempted in many cases here. The virus got way out ahead of what was the planned strategy, and we are going to be trying to recover both on the health front, but also on the economic front for probably years to come. But we are eager to be back in this global dialogue, and I think not only have a lot to learn, but have a lot to share with scientific advancements and some global efforts to reknit a community where we don't pay a lot of attention to borders, but pay a lot of attention to global health.
Thank you so much, Kathleen Sibelius. That's really very insightful. I really appreciate your words there. So let's move on now. We've heard about the medical side of it, of a pandemic, but now we're looking at the response. And it's a great pleasure to be able to introduce Paul Pirro, who's the CEO and Managing Director of CSL. He was appointed in this role in July 2013. And since then, CSL has grown to become the world's third largest biotechnology company with over 27,000 employees and providing life-saving products to over 100 countries around the world. Also, in 2019, Paul was recognized as one of Harvard's Business Review's best performing chief executives in the world as part of business publication CEO list top 100 back in 2019. Well, that's not that long ago. Also, the annual ranking measures of leaders across industries on financial performance, as well as social and governance criteria. Paul has been voted as the Business Daily 2019 CEO of the Year, but also I thought was fantastic to see Philadelphia Business Journal's Most Admired CEO and Humanitarian Man of the Year by the Hemophilia Association of New Jersey, and influential Australian Financial Review named Paul as the 2017 CEO of the Year. And so it goes on. So we are greatly honoured to have Paul here to come and tell us today about the way that CSL has been working on the development of vaccines. So over to you, Paul.
Well, thank you very much, Kathy, and hello, everyone. I hope wherever you're joining us from today that your families are all healthy and safe. And I want to thank the American Australian Association for inviting me to participate in this very distinguished panel, even though my mother would have really enjoyed that introduction. I would say that quite a number of the panelists here have much more, certainly accolades and certainly much more knowledge in terms of science. And I just am very pleased to be on the panel with all of my colleagues here. For those of you that may not be familiar with CSL, we are the largest, depending on the day, Australian company on the Australian Stock Exchange. But it may not be as much of a household name in the US for a variety of reasons. One is the listing, which we don't show up on all the stock shows and business shows because the Australian Stock Exchange is not quite the same size as NASDAQ and Dow Jones. So that could be one reason. But really, through our CSL Behring business and being in the rare disease space, and as Kathy said, probably the third largest biotech in the world, we are dealing with a lot of rare diseases. And unless you know someone who's afflicted with the rare disease or have intimate knowledge, you may not know the company because that's where our focus is. We are also a global leader in differentiated influenza vaccines. And you might say, well, that's great. We're the second largest producers of flu vaccines, so people should know who you are. But like most of us that live in the US or in Australia, many times when we get our flu shot, we don't even know which brand we're getting, right? Unless it's explained to you or described to you or somehow pointed out. Also, we are headquartered in Melbourne, where our shares, as I said, are traded on the ASX. And as mentioned earlier, CSL started as Commonwealth Serum Laboratories by the Australian government over 100 years ago, and then was privatized from government in 1994. And so it has been in Australia for quite a while and very much a household name. But from that government entity, which was providing medicines to the people of Australia post World War I, when the supply chains were kind of cut off from Europe and the rest of the world, CSL has always responded to the need of patients in Australia. And now we are taking our medical science, not only from Australia, but working with our scientists around the world to bring medicines globally. So 12,000 of our 27,000 employees are located in the United States through our two businesses, which is Seqirus and CSL Behring. And as part of our CSL Behring group, we have CSL Plasma, which is one of the world's largest and most efficient plasma collection networks. CSL Plasma collects this important raw material, which we manufacture quite a number of proteins from, which is human plasma. And we treat these rare diseases like bleeding disorders and immunodeficiencies. So if we go on to the next slide, I think innovation and collaboration engines that we have at CSL. There we go. It's an important factor of success. If we're not innovating, we should be managing our exit as an organization. And through our knowledge as an intensive innovation company, we have a strong focus on collaboration and innovation that's across the globe. So we have research sites across the globe that actually work together. And not only that, but within our company, between Seqirus and CSL Behring, I'll talk more about how we have actually tried to attack the COVID-19 pandemic. So if we move on to slide 4, really when the pandemic started, CSL had to be agile, and we had to adapt to the evolving environment that quickly became all things COVID over a year ago. Both operationally, as well as really deliberately as an organization, we applied our science and capabilities to try to respond to this pandemic. And in doing so, if you were to create a company that could respond to the pandemic, it might look a lot like CSL in terms of the therapies. I know Mick, with his devices and things, attack another area that's needed. But in terms of treatment and prevention, CSL has developed monoclonal antibodies, hyperimmunes, and vaccines. Professor McIntyre pointed out the hyperimmune project that we have going on in Australia. They're all in our wheelhouse. And so this organization was able to respond on a number of different areas. We currently have R&D programs underway focused on fighting COVID-19. One is the unprecedented COVID-19 Plasma Alliance, which we were one of the founding members, which actually took competitors around the globe in plasma to create a hyperimmune product. And then we're doing a special similar program in Australia, working with plasma in the Australian market, which is under development in Melbourne and entering clinical trials. With all these projects, there's a risk that even with these selected opportunities, we think make sense both scientifically and fit our capabilities, but it is research and development, which is risky. And a good example of the complexities really includes our decision last year not to proceed with the phase 3 candidate of our vaccine candidate with the University of Queensland. So it's important that the public understands the risks that we have in this area, as well as the fact that there's probably not one single vaccine that's going to be the answer. And I think Kathleen mentioned that earlier, that we have to look at all options. Our Seqirus business is also working on public health and through the flu pandemic, because we don't want the twindemic to occur. And I am heartened by the continued collaboration our industry has demonstrated in fighting this COVID-19, which is actually personal for all of us. So CSL is proud to play a role in this fight against COVID, and will continue our critical core operations for rare disease while continuing to focus on COVID-19. And this has really been one of the most challenging times in our lifetime. Thank you. Kathleen?
Thanks so much, Paul. That is really interesting. I've got lots of questions I'm going to follow up with later. So our final speaker is Michael Farrel, and he's Farrel, and he's known as Mick Farrel, and he's been appointed ResMed CEO and has served as director since March 2013, having joined the company in 2000, first of all as its senior vice president of global sleep apnea business, and then following on as being the president of the Americas region. Before joining ResMed, Mick worked in management consulting, biotechnology, chemicals and metal manufacturing at companies including Arthur D. Little, Dow, DuPont, and BHP Billiton. Mick serves on the board of directors of ResMed and Advanced Medical Technology Association and Zimmer Biomet. And he also volunteers as a trustee for nonprofit organizations at the University of California, San Diego Foundation, Rady Children's Hospital, and Father Joe's Villages in San Diego, California. He's a graduate of engineering with first class honors from the University of New South Wales, but with masters in chemical engineering and business administration from MIT. And so it's really great to invite Mick to come and talk to us about the ResMed response to PPE to support and also particularly with the ventilators to support the response to COVID. Over to you, Mick.
Thanks, Kathy, and thanks a lot to the American Australian Association and for the fantastic speakers that went before me. I'll try to be very brief. Got a little timer going in front of me. I saw Paul hit 5 minutes right on the dial, so I'm going to try to aim for that as well, Paul. Great setting there. ResMed, quick background on us. We're listed on both the New York Stock Exchange here in the S&P 500 and on the Australian Stock Exchange in the top 10, 15, depending on the day. Market cap's around $30 billion US, $40 billion Australian, trailing 12 months around $3 billion, and we operate in 140 countries worldwide. When I talk to ResMedians, and there's 7,500 of us, and that's what we call ourselves, operating in 140 countries, those numbers don't come up as much as this number, 118 million lives. That's how many lives we impacted in the last 12 months, helping people sleep better, helping people breathe better, helping people live a better life away from a hospital. And our goal is double-digit growth of that volume so that we can impact 250 million lives in the year 2025. So that's our sort of 5-year strategy. I'll talk about COVID in two contexts in my 5 minutes here. First, our response to the crisis, and second, the permanent positive shifts that have happened to global healthcare that ResMed has seen and is leveraging during this crisis. So first, the response to the crisis. Just incredible what happened. Companies around the world did this, but over a weekend, literally on a Thursday, we told 7,500 ResMedians, go home, do what I'm doing now in my own house, take an iPad, take a phone, and work from home. And that was about 60, 70, 80% of ResMedians. The real heroes are the ones who kept coming into work in our production, our tech service, our customer service, and our direct sales teams out there in hospitals around the world, including heroes who were there in Wuhan, in Hubei province, right at the start of this, the sort of canary in the coal mine here that told us this was a global crisis. We made over 150,000 ventilators from January 1 to June 30, 2020. That was more than 500% of our prior year production capacity for our life support ventilator and over 350% of our production. It was an incredible supply chain production approach, and I'm humbled to be part of a team that could pivot that quickly and do 5x, which, you know, when each ventilator has over 500 components coming from, you know, tens of countries around the world with borders shutting down, FedEx not flying, and no domestic flights for air freight. It was an incredible feat. We created a global humanitarian epidemiology model of what we call the surge, the peak, and the decline need for ventilators. And we based it upon a mathematical model from 2003, 2004, with a little thing called SARS-CoV-1. Now, if Professor McIntyre's technology had been in play, maybe we could have done that with SARS-CoV-2, because SARS-CoV-1 stayed in Southeast Asia. But we used that model for Southeast Asia of the surge, the peak, and the needs for ventilators, and we took that around the world. And we were able to then work with the United States government. We worked with the Trump administration, HHS, and FEMA to get 2,500 ventilators to the US stockpile. We worked with Minister Hunt and others in the Australian government to get 5,000 ventilators to the Australian government. We did the same with non-public contracts with Germany, France, Japan, and around the world to make sure that based upon our model of global production, what each country we could get and when we could get it to them. And I was blown away by our team's ability to ramp production in Sydney, Australia, to ramp production in Singapore, and to partner with those governments in what I'd call a public-private partnership. So in my last 2 minutes, I'll focus on, that's the emergency response. That's sort of like the Band-Aid on the gaping wound, right? Taking care of these really sick people with ventilators. What's permanently changed? And what sort of, if you think about lots of suffering during this crisis, what are the blessings that I believe you can get from suffering? And so what are the blessings that we can get from this? Well, number one for me in our industry is the importance of respiratory medicine, respiratory health, and respiratory hygiene. Prior to December 2019, if I'd asked you what's the most important organ in the human body for medical devices, you probably would have said the heart, and therefore cardiac devices, or the brain, and then neurostim or neuro devices. Lungs probably wouldn't have come up. So for us, the importance of respiratory health is incredibly important. SARS kills you through acute respiratory disorder syndrome, ARDS, and so it's raised the importance of that. The second thing it raised was the importance of digital health. Doing this could be a visit to the doctor, this Zoom call for you. Why aren't we scaling digital health to areas like never seen before? COVID showed us how to do that, and it's going to change permanently healthcare. And the third is the importance of outside hospital healthcare. You should never go and seek treatment at the hospital unless you're really sick. And particularly in the country I live in here, the United States, where 19% of the GDP is spent on healthcare, that's a sick care system, not a healthcare system. So we think those three trends, the importance of respiratory health, the importance of digital health, the importance of taking care of people outside the hospital, whether it's in home medical equipment, skilled nursing facilities, home health, hospice, life plan communities, and beyond. So with that, I'll leave you with this. ResMed now is the world leader in digital health. We have over 8 billion nights of medical data in the cloud. We have over 12 million medical devices for sleep apnea, COPD, asthma health out there. We're turning that big data into actionable information, and that means helping patients treat their chronic disease, helping doctors treat groups of patients through digital health, and helping governments and healthcare systems do population health management to reduce the burden of chronic disease and help people stay happy and healthy in the home.
Well, thanks, Mick. That is so interesting. And it's fascinating how you were able to see your whole business pivot in such an amazing period of time. But also, I guess it must be an incredible feeling to know that you've had such an impact on the health and well-being of so many people. So look, we've heard some really interesting discussions, and I can't help but notice that there's a really strong theme that came out from all our presenters. And I want to start by asking you all a particular question on the importance of innovation, but where collaboration and alliances come in. And it sounds like this has been critical for every aspect of the work that was presented today. And I guess I want to start with Rayna about what you think will be needed so that we could actually use this idea of the importance of open source data that we could farm to and mine to be able to really get information about not just this part of pandemic preparedness and observation early on, but also in other areas as well. And then I guess I'll go through with the other speakers as well, as we hear from your perspective that what we need to do to really build the opportunity of collaboration in order to achieve the innovation needed.
Well, I think, in public health quite old fashioned, as I said, in Western countries, including the US and Australia, in the sense that public health hasn't embraced technology, digital technology, as much as it could or should. So I think focusing on changing the way people think, thinking outside of the square, thinking of solutions that are not your old fashioned solutions in terms of technology, is a start. And I think there's a bit of work to be done there. But then I think if we look at the areas of mutual interest, you know, I think everyone's interested in our region. Our region historically has been one where emerging infections have arisen, from SARS to avian influenza viruses to SARS-CoV-2. So I think that that regional focus is something we have in common. So using what we have in common to then, you know, move forward in trying to change the way we think about public health and prevention.
And Kathleen, what about from your perspective, particularly in line with what maybe the roadblocks that and how we might break through them in order to achieve that stronger collaboration? Because that seems to be the answer in many ways.
Well, I'd like to pick up a little bit on what Mick was talking about with some of the trends. I think all of us have learned a lot of lessons, even outside the public health arena, about COVID, and work is unlikely to look the same going forward. Travel is unlikely to look the same. Certainly healthcare, if we are smart about it, will never look the same and shouldn't look the same. And not just telehealth and digital health. Again, Australia has learned some lessons. The United States has done some things pretty well, not other things very well, but collaborating on what that looks like, which really can expand access dramatically. But also using technology. I mean, in many ways, the health systems have been pretty impervious to technology, unlike other industries. And I think this is a moment of opportunity where scientific collaboration, innovation, and breaking through what is kind of status quo barriers. We talk a lot about, I was interested in Mick's using the phrase the outside the hospital healthcare. In the US, we talk a lot about the social drivers of health, recognizing that there is a lot about the way we live and the air we breathe and the water we drink and the food we eat that has a lot more to do with overall healthy aspects, overall mortality rates, overall life expectancy than does the interface with any kind of clinical system. So really putting those efforts front and center and collaborating on those efforts across the world, looking at who gets some of the social drivers on health right and how you really do manage and deal with population health in a very different way in a digital age, and sharing those lessons rapidly, I think could advance, you know, lessons learned country by country in a dramatic way. Unfortunately, we often do it at a time of crisis, and this may be lessons learned after the crisis that we put in place and really expand greatly.
So actually, that's really interesting about lessons learned looking backwards, but we're right at the moment looking at the development of vaccines, their rollout, getting a, you know, something which the world wants to achieve for vaccinating the world. So Paul, I was just wondering from your perspective, how do you see this all happening where, you know, the role of collaboration, the role, I mean, I actually think it's been a modern miracle to see the rate of which vaccines have been developed in a whole lot of areas, the ability to, in say in the case of your company, be able to pick up a vaccine and be able to manufacture that at scale. I'm just curious to know how you see, you know, so the role of vaccines in real time now. Is there something we can do differently as we go through that process?
Well, Kathy, I think we're still learning. And, you know, collaboration is easy when you have successes. It's much tougher when you have challenges. You know, everybody wants to collaborate and everybody wants to say it's been a great success. But when you have difficulties, you know, the rollout of vaccines in the US, I wouldn't say it's been brilliant. You know, there's still a lot to do and a lot to learn from that. But we need to work together on it. We can't keep pointing fingers. I mean, we have to figure it out. And that's really where collaboration is tough, because it's a tough time right now. I think there needs to be collaboration around vaccines in terms of getting the public message out of the value of vaccines. I was shocked to see that a recent study in France showed 60% of the French population would not take a vaccine. I mean, are they sleeping under a rock somewhere? I'm not sure. It's, you know, this is a serious issue, as Kathleen pointed out at the very beginning, with the number of deaths that we've had across the globe. So it's something that, you know, we have to collaborate across the spectrum. It's not just the science and getting it done, then it's the communication of the science, it's the actual delivery of the vaccine. And we're going to need more than one vaccine, and this is going to go on for a while to get everyone across the globe vaccinated. People talk about herd immunity, and I'm sure Rayna can speak to that very eloquently, but herd means you need a lot. I mean, it's not one or two, it's everyone, right? I mean, you have to get a big majority. So look, we had to shift and pivot with UQ, but we started working with UQ at the very beginning, and there were some issues that we had to solve, and the vaccine was working quite well. There were just other areas that we had to deal with that caused us to stop that program. But at the same time, we're manufacturing the AZ vaccine in Australia. So AstraZeneca, and we're working very closely to manufacture that and get the doses to the Australian population. And I think we'll be able to continue to make vaccine. I've worked with J&J on looking at fill finish capacity for their vaccine. We've talked to a number of other vaccine manufacturers because we do have scaled manufacturing from flu vaccine, but then we have to manage that, and we have to collaborate to make sure that we can. That's another public health crisis that, if you're not careful, can run away from you. And so we got to make sure that we have enough material and filters and bags to manufacture seasonal flu while we're trying to get all these materials to manufacture COVID vaccines. So the collaboration has to be between industry, between suppliers, between partners, between governments. And I think the complexity there is what we have to learn from. Speed is great, but speed also can cause you problems if you're going too fast and you don't think about all the implications downstream. So just a lot to think about. It's a complex situation with an unprecedented event.
So Mick, you've lived this. I mean, the story of ResMed in delivering all those ventilators and also pivoting to turn your sleep apnea device to ventilators is an amazing story. What was the secret to success in your perspective? Because all the things that Paul just pointed to are things you must have had to overcome.
Yeah, it's a really good question. And, I think about it and I'm reflecting on what Kathleen just said around public-private partnerships. And you think about this, I mean, and what Paul just said, I mean, think about he and his biotech and big pharma peers created vaccines in 6-9 months that usually take 6 to 9 years or longer. And what an incredible, amazing response to the crisis. And why can't we, and I say this to my own software teams, that we brought forward software that was going to come out in September. We launched this software for ventilators in Europe in April, like in weeks versus months. And I said to the team, wait, why did we need a crisis to be able to bring that great technology to our pulmonary doctors in Europe because they needed it during COVID? Why can't we do that in normal times? And, great quote from Aristotle on this: once the mind has been stretched with a new idea, it never returns to its original size. And I was on one of these Zoom calls with the CEO of Johns Hopkins talking about digital health and how they used, from 1% of their visits pre-COVID, it went to 100% of their pre-visit, their visits, because no one could go into any clinics for primary care and so on, except for the ER. And I asked him, well, where do you think it lands back? And it's the Aristotle principle. It doesn't go back to 1%. It goes back to about 20%, he thinks. 20 to 30% of all visits will be digital health visits, telemedicine visits. And I think that's the future. And I look at the public-private partnerships we did on vaccines with Paul's group, on ventilators with ResMed and our competitors and the governments. Why can't we do a little bit more like what we did with the government of France, where we established differential reimbursement for cloud-connected medical devices in our field of sleep apnea and non-cloud connected ones? And they didn't do that because, ResMed's a great partner in talking to us. They did it because we proved that the French social security system, 80% of people have free government health care. 80% of people, what we proved is that if it's cloud connected, it lowers costs for the French social security system, it improves outcomes for patients, and it improves long-term chronic disease progression, not just in sleep apnea, but in the comorbidities. We've done the same with the government of Finland and proved that. I say, well, here in the US, these emergency use authorizations that were so useful to have reimbursement for digital health during the crisis, why don't we make that law? Why don't we combine Hippocrates and Adam Smith, right? Do no harm and a little bit of economics to say to the doctors, keep doing it because it's good. It saves the US government, private and public, payers money to support digital health, lowers costs, improves outcomes, and drives full care. Let's not waste this crisis. Let's get the good things out of it.
No, that's there's nothing like a good crisis to really create change. I can't believe that time has raced by. And we've only just started the conversation. So I'll have to say, memory to self, we should make these much longer because there's so much that we could dig into. So because we're coming to the end of the time, I'm just wondering if I could ask each of you to think about the future. We've sort of touched on that already, but what do you think the future will look like in a year to 2 years? And what is the one thing you think we should be looking to do and address so that it's a good outcome, not a bad outcome? So I'll just go through, Rayna, how about we start with you?
Sure. Into the future, I think, from the pandemic perspective, I do think we'll be living with this disease for a while yet. There will continue to be hotspots in the world, including potentially the United States, if the vaccine rates can't be, high vaccine rates can't be achieved. There's been so much damage done to, with the anti-vaccination ideas that have been propagated in the last few years. In fact, the whole QAnon philosophy is very deeply tied to anti-vaccination. So I think there's a lot of damage that has to be undone there before high vaccination rates can be achieved, and maybe it can be done quickly. But in other parts of the world, lack of access to vaccines, despite the COVAX initiative, will also create inequities. And I think we'll have to work out issues like travel. People talk about immunity passports, and probably there'll be a ranking of vaccines on those immunity passports. Which vaccine did you actually have? Does it prevent infection, or does it just prevent death and serious disease, which is a good outcome. But and then, I think other speakers have mentioned, the changes in the way we live and work. I think we have to look at, there's a lot of resistance to that change. A lot of people just want things to go back to how they were. But I think we should reflect on the changes that have been forced upon us and look at what we can change permanently. Personally, I like working from home. Saves me 2 hours commuting. I can be more productive if I work from home. But there's I think we have to overcome those mental blocks to oh, you can't have an effective meeting without flying 48 hours or 24 hours across the world. Of course you can. So I think we need to really reevaluate how we do things.
That is, there's some really good points there. Kathleen, what about from your perspective?
Well, I think that I would agree with what Rayna has said and kind of all the fronts. I think we have had a brutal lesson in the United States about the connection of the economy and health. People pretended in our country for a long time that there really wasn't this intimate connection, that, you could have a robust economy and a lot of unhealthy people. And I think what we have proven very clearly is you cannot. And so I'm really hoping that we in the US and maybe globally stop talking really about public health. I mean, public health is health. It is all of our health. And it's not about, some abstract population. It's really how we conduct ourselves. And at least for the US, we have so underfunded for decades efforts to make a resilient health system that had outreach and equity. And I'm hoping that this becomes our 9/11 moment in health, that we look at how our security, how our national resilience, how our economic future is directly tied to how fast we can deal with and recover from any kind of health incident, and help to put the resources aside the way that our leaders did after 9/11, building security systems that hopefully they'll never use, and building, putting aside all sorts of apparatus to keep us safe and secure. We have to do the same thing in health, both nationally and commit ourselves to those kind of resources globally, because we will never be resilient unless the globe is more resilient.
So thank you. That whole idea of health coming first is really, I think, a great lesson that we've all learned. So Paul, what about from your perspective?
So I agree with what both Rayna and Kathleen have said, and it is about human health, and that's really what we're after. I just think that over the next couple of years, there will continue to be a lot of disruption, both, certainly from a disease standpoint, this is not going away quickly. We have to understand how to better manage the disease, not just prevent it, but also manage, because people will continue to get sick. And we're not going to just be jumping back on planes. As much as my wife would probably like me to, it's not going to happen anytime soon. So I think we just have to be realistic about what to expect. And that's hard when people are impatient and people have suffered and people are tired of living this particular way, because it is a huge change. I think it's important that governments realize the investment that has to be made in innovation. I think that something for the future would be to really understand that you can't respond to a pandemic, put a lot of stuff in place and then forget about it for 5 years because a pandemic hasn't occurred, because that's what's happened, right? I mean,
sustaining.
Kathleen will remember our time together back in 2009, and everybody was all ready to invest and do things. And then after about 3 years, everybody forgot. And when this occurred, a lot of the pandemic supplies and preparations were not there anymore. So I think it's just a matter of, there has to be a long memory, regardless of which political party's in power, that understands about innovation and preparedness for future disease and pandemic for human health. And that's a key lesson that I think we can't forget about.
Okay, so that's really good. And Mick, you get the last word. With a minute or so, what's your view?
I will be as succinct as I can, Kathy. Look, I think one thing we can learn from this crisis and others is you're not treating a disease, you're treating a person. And a person has many aspects to them. And I think that preventative care, out of hospital healthcare, liberating data to the cloud, and then empowering an individual with decisions and the ability to do it is going to require privacy, it's going to require cybersecurity, and it's going to require trust. And unfortunately, the Twitters, Facebooks, and Googles and Amazons of the world have broken that, because they turned the consumer digital world into you are the product and we're using you and selling you. And what we have to do in the medical side is say no. We are going to keep your information private, secure, and interoperable, so that you can take your health record wherever you want and get preventative care to keep you out of hospital and doing well. And it's almost like a mind shift change that we have to do. Digital in medical is going to be very different to digital in consumer, because we're going to give trust to you and empowerment to you and privacy to you. And it's not going to be simple, but this crisis has shown us we can work together with public-private, and we can empower consumers. And if you do, they make much better decisions.
Yeah, look, this is just the beginning of the conversation, I can see, but there's also the breakout session next. I want to thank you all so much for the insights you've given today. And I think we're all taking away the importance of collaboration, innovation, alliances across countries, and also how a digital world, but the digital world which is trusted and where your center, you own the power and be able to access the information as well, is going to be critical. So look, thank you, everyone. I'm going to pass back to John Berry, who's going to instruct us on how to close up and move on to the breakout sessions. So thank you, everyone, and over to you, John.
Thank you so much, Kathy, and Dr. Foley, for your great moderation today. Thank you to my great friend, Secretary Sibelius, for taking time to join us, for Professor McIntyre, for Paul, for Mick. Thank you all for the very engaging conversation that you have made possible during this day and this very challenging and unprecedented time. It was truly inspiring to hear about the medical innovation that has been born out of this crisis, as well as your vision for the future. So thank you for being here today from all around the globe. We at the AAA and Good Day USA are very proud to host these policy dialogues, where we try to bring together the brightest minds from the US and Australia to share ideas and strengthen the strong ties between our two great nations. And today is a great example of that. Thanks everyone for attending, and thanks again to our wonderful panel.